Good morning, everyone. I'm Ines Rachidi from Grenoble University Hospital in France in Philippe Cahan's epilepsy monitoring unit. And I'm going to talk to you about auditory ictal symptoms, including ictal deafness. So, a brief historical note about ictal auditory symptoms, which were described as earlier as in the 19th century by Gauss, who reported patients describing hearing a beautiful music during their seizures, with approximately 6% of patients in their cohort reporting ictal auditory symptoms. Lennox and Gobb in the 20th century also described patients with ictal auditory symptoms, and it was already noted that these symptoms are quite rare among patients with focal epilepsy. And of course, Penfield and colleagues described ictal auditory symptoms during the 1950s and 1960s, trying to establish anatomoclinical correlations of these ictal auditory symptoms. So the classic view about ictal auditory symptoms is that these are relatively rare, as we said, and they can be of different types. Elementary ictal auditory symptoms, such as elementary illusions or hallucinations, such as buzzing, etc., are rather thought to be linked to the primary auditory cortex or Heschel's gyrus, whereas complex auditory symptoms, such as complex illusions, complex hallucinations, either positive or negative, are rather thought to be linked to the auditory association areas, including T1, temporal-occipital cortex, and such. A classical view of ictal auditory symptoms is also that they are often thought to be contralateral, especially when the auditory symptoms are elementary, and they're thought to be associated with an unfavorable seizure outcome. So challenges about exploring ictal auditory symptoms are to try to determine their localizing value. Are they really mostly due to the lateral temporal cortex, or are they also linked to other subparts of the temporal lobes, and also do they have other extratemporal localizing values? Do they have a lateralizing value, especially are they really contralateral or not? And do they really have a bad prognostic value? Here is an example, a video of an unpublished case, an CEG patient which we had in the epilepsy monitoring unit. So you can see here anomalies on U prime 2, U prime 3, U prime 7, U prime 8. I'm not sure you can hear the sound of the video, but it's in French anyway, and the patient reports buzzing sound, not lateralized, and also hyperacusia. So to do this systematic review, here are the keywords that we searched in the PubMed registry. We found 1,696 studies, and criteria for selected articles were articles describing spontaneous ictal auditory symptoms in patients with focal epilepsy with extraoperative intracranial EEG, SEEG, and/or subdural arrays, and/or who were treated with conventional epilepsy surgery, and/or who had an MRI lesion which was consistent with suspected epileptogenic zone according to clinical and SCORE-PEG data. We included studies only with at least 3 patients, except for case reports which had intracranial EEG data and/or epilepsy surgery patients. We included these small number of patient studies because these symptoms were quite rare, as we said, so we wanted to have as much data as possible. Cortical stimulation studies were not included in this systematic review. And it is noted that relevant papers cited in articles of interest and which did not appear in the PubMed search were also added to selection. So, during the identification phase, we had all of these articles, and so we screened 700 abstracts which were reviewed. Among these, 60 articles were deemed eligible, and in the end, 32 articles were included, leading to 196 patients included. So here is a description of the selected studies. In general, we had, let's say, 2 or 3 types of studies. We had a few number of studies which were cohorts of patients with auditory symptoms, specifically exploring the auditory symptoms. We also had big cohorts of patients, usually where the point of the study was to explore the outcome of different auras. So a small number of patients in these studies had auditory symptoms. And we also had case reports, usually with intracranial and/or epilepsy surgery data. So here is a summary of all these selected studies. As I said, we had 196 patients included. A majority of them were adult patients. A majority of them had an MRI lesion, but it is to be noted that these statistics are only out of 112 patients because 84 subjects were not reported to have an MRI, or we didn't have the MRI info. So of course we can suspect that these persons who did not have the MRI info were MRI negative. Among all these patients, around 50% of them had intracranial EEG. So again, out of 109 patients, because it was not reported in 84 subjects. So also we can suspect that among these 84 subjects, most of them did not have intracranial EEG. And as I said, intracranial EEG could be either SEEG or subdural electrodes. And in some case reports, sometimes it was both methods. So in the end, 84% of these patients were operated. Surgery was not reported in 27 subjects. And 45% were angle 1 after at least 1 year of follow-up among 136 patients who were operating and for which we had info on the angle score. So in the end, we had 48% high or very high level of confidence in the epileptogenic zone out of 191 patients. So regarding anatomo-clinical correlations, it is to be noted that a vast majority of patients with auditory auras had a suspected epileptogenic zone in the temporal lobe, 88% as you can see. It was mostly at onset of the seizures. So we considered that the overall gray level was high for these auditory auras to be associated with the brain region. We also found patients with suspected frontal epileptogenic zone, 12%, and a majority of these were with onset and not propagation. It is to be noted that among patients with suspected frontal epileptogenic zones, it was mostly the inferior frontal gyrus, but it was also described in middle frontal gyrus, superior frontal gyrus, and orbitofrontal cortex, and also mesial prefrontal cortex. The insula also was described in patients with auditory auras. It was mostly posterior insula, and it was mostly onset. So for frontal and insular epileptogenic zone suspicions, we considered the overall gray level moderate. There were also a few case reports describing occipital, parietal, or anterior cingulate seizure onset zone suspicion, but these symptoms were really rare. It was sometimes onset, but mostly propagation, so we considered the overall gray level low. Same for occipital. Regarding the temporal lobe, it was interesting to see if the subtype of the temporal lobe when described. So among all of these patients, 35% had a report of a lateral temporal cortex onset, mostly Heschel's gyrus, of course, and T1 posterior. It was mostly onset for these patients, so the overall gray level was considered high. For mesial temporal subparts, 4% were reported. This number is perhaps underestimated because in some patients who were seizure-free and who had anterior temporal lobectomy, in big cohorts of TLE patients studying outcome after surgery, we can maybe hypothesize that they had a mesial seizure onset, but it was not described. So, to conclude, indeed, the ictal auditory symptoms remain rare, around 5% in TLE cohorts, and it's supposed to be 1 to 2% among all patients with focal epilepsy. Regarding anatomo-clinical correlations of ictal auditory symptoms, indeed, the lateral temporal cortex, including Heschel's gyrus and T1 posterior is mostly implicated in these ictal auditory symptoms in focal epilepsy, but the mesial temporal structures and extratemporal structures such as the insula, the prefrontal cortex, the occipital cortex, and the parietal cortex are also described. It's important to note that there is a possible bias regarding the ICEEG techniques since a proportion of the ICEEG studies were done with subdural electrodes not exploring deep structures, especially Heschel gyrus. Regarding subtypes of ictal auditory symptoms, it was hard to define anatomo-clinical correlations for subtypes of ictal auditory symptoms. Indeed, in the big cohorts of patients with epilepsy surgery, we did not have any information about the type of ictal auditory symptom, if it was elementary or complex. And so there were only a few case reports describing this subtype, so it was hard to have statistics about that. Still, we can see that with elementary ictal auditory symptoms, they are more thought to be linked to the lateral temporal cortex, Heschel gyrus and T1, whereas for complex ictal auditory symptoms, such as verbal hallucinations, musical hallucinations, more extended networks were described in case reports. Do they have a lateralizing value? Well, a high proportion of lateralization of these symptoms were not reported, so it's again hard to conclude. They have a poor lateralizing value in SCORE-PG studies, but they're still more contralateral or bilateral than ipsilateral, and they're usually more unilateral and contralateral in elementary auditory auras. And when we had ICEEG data, they seem to be more unilateral and more contralateral. So do they have a prognostic value? Well, 45% of angle 1 after 1 year of follow-up, so it's not that bad, but we think there's a bias linked to the fact that we included many case reports who usually describe their 1 or 2 cases because they had a good outcome. And in surgery cohorts analyzing the outcome of auras, there was a poorer prognosis. It's interesting to note that these prognostic value is not necessarily influenced by the site of surgery. It was described in one study because we could think that if the surgery was on the dominant hemisphere for language, maybe the resection was not that posterior, and therefore there would be a poorer prognosis, but this was not seen in some studies. And maybe sometimes we can think that there is a better outcome with intracranial EEG in these ictal auditory symptoms, but again, some studies did not show a better outcome when intracranial EEG was done with these ictal auditory symptoms. Thank you for your attention.